So we'll start with a case. So you have a 75-year-old woman admitted with abdominal pain and headaches. You inform her that her CT scan shows a large pancreatic mass with multiple brain mets concerning for metastases. She says, "How is this possible? How long do I have left to live?" What is the best response to her question? Let's take a moment. The answer I'm looking for is, "It sounds like this news was surprising to hear. Is that how you were feeling?" So we're going to talk about responding to emotion. This is a skill I think is useful in both palliative care and just in general medicine and outpatient, really in any clinical setting. So the question is, why should we be responding to patients' emotion? Is there an actual benefit? And there is a fair amount of data showing that when we respond to emotion, we're more likely to elicit accurate patient goals. Patients can actually retain information better when we respond to the emotions that are underlying a lot of the things that are going on. And when there's conflict in conversation, acknowledging emotion helps us navigate that conflict more effectively. So the NERSE statement is a framework from Vital Talk that we're going to go through, and we're going to highlight three pieces: naming, respecting, and exploring as to techniques for how to respond to strong emotions that you may see in patients. These are not meant to be used in sequence. These are different techniques that you can use based on the setting you're in. So we're going to focus on these three in particular. Naming I find to be the most approachable, and really it is just like you're trying to name the emotion you're seeing, and we'll talk about how to do that. So for example, after hearing about a cancer prognosis, a patient says, "I just don't know how I'm going to handle what comes next." So there is a cognitive question or cognitive response in that, but instead to go to the emotional space, an example naming response would be, "It's normal to feel scared when faced with a situation like this. Is that something you're feeling?" And I like to think of this as floating a hypothesis, and that you are asking a question and normalizing a feeling that you think you're seeing with a patient. And this allows patients to feel that this is less of a judgment and more that we are opening up the space for them to go into if they're feeling that emotion. Conversely, with the same response, I would not say you must be scared. So when we name emotions, it's better to normalize or ask it in a question as opposed to telling someone how they need to be feeling, which can often push patients away, especially if they don't agree with our assessment. Next is respect statements. I think these are the most underutilized response to emotion that we do, and I think it's very useful, especially when we want to find common ground in challenging cases. So example, patient's been on a ventilator in a vegetative state, and there's tension between the team and the family. So when you're in a situation like this, we can all agree that we respect all the hard work that loved one is putting in. So a response might be, we respect what a good advocate you've been for your father and how you're here every day asking questions. So respect statements, acknowledging the hard work that patients' families are putting in or that patients are putting in, allow us to find common ground in scenarios where there's often a lot of conflict. Exploring statements I find to be really effective after we've established the beginning of what emotion a patient might be feeling. So for example, you might acknowledge the patient feeling scared and they say, "Of course I feel scared, I'm dying. How would you feel?" So a nice exploratory statement might be, "Do you feel comfortable sharing more about what you find scary?" This is how we can get to the root of really what's going on underneath these emotions and what patients are feeling. This is where you can get to kind of the meat of what's going on underneath all these patients' strong feelings. And then it's so crucial, after you make an empathetic statement, to pause and allow patients to reflect. I see all the time people make great emotional empathetic statements and then they continue talking, and there's great things that we would learn, but we have to allow for silence for patients to process, to hear what we're saying, and to give time for them to respond. People may decide they don't want to stay in that emotional space, and we can respect that boundary, but people really may want to talk a lot about how they're feeling. And if we pause, give them control in the conversation, there's a lot we can often learn. So in summary, I think that like in the case, some cognitive questions and statements have strong underlying emotions, and it's more effective to first address the emotion with a NERSE statement. And we highlighted 3 of those: the naming, the respecting, and the exploratory statement. I think with a naming statement, using normalizing statements or questions is most effective. Respect statements are a great way to find common ground when there's tension and hard conversations, and exploring allows us to find more meaning. And after we make the statement, to pause, allow patients to reflect, and allow them to dictate where the conversation goes from there. And if you go to this space and patients make it clear they don't want to go into an emotional space and talk more, respect that boundary, and they know that they can continue to go there if you do that. And that's all we have.